patient's freaking out, at least we know that they're conscious as to what is happening and they're not in an altered state of mind. We want to assess their airway, their breathing, and make sure the patient is showing signs of inadequate breathing or altered mental status. They should receive appropriate oxygen. So we're going to go ahead and take a pulse ox and note that. Depending on what the severity may involve, they might need a nasal cannula, non-breathing mask, ventilation via bag valve mask. And we want to be careful to avoid causing bleeding if additional airway support such as suctioning is needed. Check their circulation. An increase in the pulse rate may indicate compensatory mechanism. Look for signs of shock. Manage life-threatening conditions, and provide transport to the appropriate facility. If it's a trauma call, we want to send them to Tampa General. If hemophilia is suspected, please be careful not to wash out the clots. If fluid resuscitation is necessary, watch for signs of acute blood loss, pallor, weak pulse, hypotension, any bleeding, or unknown origin. Signs of hypoxia or shock. Use caution with fluid administration. Avoid washing out clots. Make a transport decision. If the destination depends on the severity of the condition and the patient's wishes, if the patient is experiencing a sickle cell crisis and uncontrolled bleeding, transport to the closest facility. You may need to be overly inquisitive about the patient's history and sample history. Hematologic disorders may present with multiple symptoms at first glance, and they may be unrelated. An example would be pneumonia. In a patient with sickle cell disease or abdominal pain, a patient with polycythemia, you may also put these pieces together to complete the picture. So we want to look for changes in level of consciousness, vertigo, feelings of fatigue, syncopal episodes, dyspnea, chest pain, changes in the pulse rate, rhythm, coughing up of blood, muscle pain, stiffness, and visual disturbances. All these are going to determine blood loss and shock. Determine whether complaints are related as part of a larger disease or process. Simply could have multiple unrelated complaints. Ascertain whether the pain is isolated or felt through the entire body. Ask if the patient has experienced bleeding, history of liver problems, pain for unknown reasons, problems of the genitourinary system, or gastrointestinal problems. Secondary assessment. The secondary assessment may be performed on scene, en route, or not at all. Depends on transport time and patient condition. When treating the patient with a blood disorder, perform a physical exam. Systematically examine the patient. Start with the head, work your way down, obtain baseline vitals. Include lung sounds, oxygen saturation levels. How many slides are there? What is this? 78. Reassessment. We want to reassess the patient, patient history, thoroughly document each finding, blah, 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 patient's conditions. Emergency medical care problems for blood disorder include oxygen. We want to do fluids, an EKG, ECG, electrocardiogram, comforts, pharmacology, pharmacological disorders, psychological disorders. Pathophysiology assessment and management of specific emergencies. Serious and often life-threatening hematologic disorders, so sickle cell crisis and pathophysiology. Sickle cell disease, most commonly inherited blood disorder. It affects mainly African American, Puerto Rican, and European populations. As of 2016, approximately 100,000 people in the world have 100,000 in the United States have sickle cell disease. Average life expectancy is 42 years for males and 48 for females. It begins with a gene defect in the adult type hemoglobin. It can be inherited from both parents, HBSS, or one parent, HBS. When inherited from both parents, it is a high probability of offspring will have the disease and carry the mutation. Defective red blood cells have oblong shape instead of a smooth round shape. The shape makes the RBC poor oxygen character, increasing in risk of hypoxia. Cells have a much shorter lifespan, increasing risk of anemia. The odd shape can cause RBCs to lodge into the blood cell vessels, leading to thrombosis. So as you can see, these are round shapes, much like a bouncy ball. They're going to bounce off of each other. They're not going to stick. But with these, you have Pringles. Pringles do what? They stack up. So this is why it's a lot more common for individuals with sickle cell to deal with pain and thrombosis, causing clots in blood vessels. Sickle cell disease can lead to a aplastic crisis. Body temporarily stops RBCs production, causing the patient to become easily tired, anemic, pale, and short of breath. The hematologic crisis, acute RBC destruction leading to jaundice. Sickle cell crisis can be manifested in several ways. Vaso-occlusive crisis, blood flow to an organ becomes restricted, and the crisis causes pain, ischemia, and often organ damage. It usually lasts anywhere from 5 to 7 days. The spleen is frequently affected due to the narrow vessels and functions of removing the damaged RBCs. Acute chest syndrome, vaso-occlusive crisis associated with pneumonia. This is common with signs and symptoms that include chest pain, fever, and cough. Splenic sequestration crisis, sickle cells within the spleen block blood from leaving the spleen. This results in painful acute enlargement of the spleen and hard bloated abdomen. The acute splenic sequestration syndrome, life-threatening conditions within the RBCs become trapped in the spleen. This causes a dramatic fall in hemoglobin available for circulation. Painful acute abdomen and sudden weakness, power tachypnea, and tachycardia. Usually can occur in infants or toddlers. Please join us for So patients are often in life-threatening crisis. Characterization of a sickle cell crisis may include shortness of breath, signs of pneumonia, inadequate perfusion to the skin, and accompanied by hypotension, signs of jaundice, yellowing of the eyes, icterosclera, and mild dehydration. In acute crisis, patients may have a significant pain and multiple system involvement. Pediatric patients typically present with initial pain in their hands, and adults typically report back in proximal extremity pain. Anything within the back, the rear, flank, or extremities. Administer high levels of oxygen to prevent further destruction from hypoxia. Do so via non-rebreather mask to hypersaturate the remaining hemoglobin and increase levels of perfusion. We want to rapidly transport the patient to an appropriate facility, consider IV fluid therapy if necessary, and maintain the patient's body temperature. Cold can contribute to sickling of cells. Patient may have a high pain threshold and require a higher level of analgesia. This is going to be your pain medication, whether it be fentanyl, could be ketamine, could be, what else do we have? Procainamide, could be solutol, could also be Toradol. Recommend the patient rest during transport. So pathophysiology, we have hemoglobin or erythrocyte level that is lower than the normal, usually associated with an underlying disease process, acute or chronic blood loss. Decreased reproduction increased destruction of erythrocytes. Pre-existing hemolytic disorder. You could have an iron deficiency anemia. Most common types of anemia is often caused by gastrointestinal blood loss, menstrual bleeding, blood loss from infrequent donations, diagnostic tests, premature birth, or low birth rate in children. May be caused by an inherited hemolytic disorder, sickle cell disease, or thalassemia. Red blood cells develop rigid deformity membrane, which can become lodged in small blood vessels, leading to thrombosis. May be caused by hematologic disorders, resulting in a deficiency of glucose 6-phosphate dehydrogenase and enzyme protection of RBCs during infection. Most common in African Americans, we're going to have common disruption of RBC blood flows through the problems of blood vessel linings in the clot. Autoimmune disorders affects a smaller number of RBCs and reduced partial pressure to oxygen of high altitude. We have hypoxia, difficulty breathing, and chest pain. For assessment, patients are most likely going to complain of feeling worn down, having no energy, feeling as if they're overexerting themselves, being unable to catch their breath. Patient may also have anginal type chest pain due to reduced oxygen of the heart, and assessed pale skin and variation in the eye conjunctiva and side lips, creases of palms, and leukopenia, which is reduction in white blood cells. Thrombocytopenia, reduction in platelets. Let's take a break.